right, I've got 1 p.m., so we'll go ahead and get started. Welcome, everybody. Thank you for joining Ford Richardson's webinar series, and very excited to have Dr. Jacqueline Theis with us today, and somewhat of a different format for us, a little bit more of a discussion, and excited to have Dr. Theis. This is recorded. It'll be 90 minutes. We will reserve 10 minutes at the end for your questions. So if you've done this with us before, you know that we like it to be interactive. Would like for you to hold your questions, put them in the chat box, but we'll hold those until the end. And again, depending upon the number, we will reserve at least 10 minutes for Dr. Theis to respond to the question. Dr. Theis completed her optometric and residency training in neuro-optometry and binocular vision at UC Berkeley School of Optometry. Following residency, she became an assistant clinical professor at UC Berkeley. She's the founder and chief of the UC Berkeley Sports Vision and Concussion Clinic, which provides research and clinical care in post-concussion vision problems and sports vision performance. Dr. Theis then worked at Kaiser Permanente in Northern California for 5 years, treating patients with double vision and vision problems from systemic and neurological disease, including diabetes, MS, Parkinson's, stroke, traumatic brain injury. With a sense of adventure and love for outdoors, she relocated to Richmond, Virginia in March 2020 to start Virginia Neuro-Optometry, a tertiary care neuro-optometry private practice, which is located within Concussion Care Center of Virginia, a multidisciplinary brain injury practice. Dr. Theis is a renowned international expert, speaking internationally on the topic of brain injury, and we're delighted to have her. So without further ado, we'll jump right into it. And Dr. Theis, I thought it would be nice to start with maybe just a brief background in your how you developed a passion in the area of brain injury.
Yeah, so it's obviously a very small niche. What I do, it really started because I had a bunch of concussions. So I was a competitive athlete as a kid, and I got a number of concussions, 7, I believe, by the time that I was really just taken out of sports in general. And I just had chronic migraines all the time. And I had a really hard time reading. And this was about in high school. And so when I would go to neurologists and ophthalmologists, they would always tell me I was fine and that it would go away. And that it was just kind of, you just got to wait out these concussions. They always get better. And then fast forward 6 years later, still having the same symptoms. So I was in college and pre-med because I was going to go into orthopedics. And my college at the time at Bucknell, they make you follow different specialists just to make sure you want to go to med school. And I was following an optometrist, and they just did one eye test. And they were like, have you ever had a brain injury? And I was like, yeah, I've had a bunch. And they were like, because your eyes, they don't track together at all. And they were like, do you read very often? And I was like, not really. I can't read for more than 10 minutes before I get tired and just, kind of lose my attention. And that was the first time someone had found something wrong with me. And she gave me prism glasses, which didn't really fix my problem, but gave me kind of longevity. So I went from reading for 10 minutes to about 1 to 2 hours, which in college is huge. And then she gave me the name of someone who I could do rehab with over the summer, because it just during the middle of college wasn't a good time to do any type of vision rehab program. So fast forward to that summer, I did rehab, and all of a sudden, after like 6 to 8 weeks, all of my headaches were gone. And I had been suffering from chronic migraines and headaches and been on all these medications for years. And I was frustrated because nobody had sent me to an optometrist. I'd been to everyone else. And so I had made it my personal mission at that point then to ditch the pre-med track and to go to optometry school and become an optometrist that does evaluation for vision problems and brain injury. And so that's where kind of you can see my clinical history is that is all I've ever done. I did a residency specializing in vision problems and brain injury, and then did clinical research at Berkeley, looking at how concussion impacts the visual system over time. And then I used that research to start a clinic, and then just kind of my career took off from then. Because obviously I'm very passionate about it because you can get people better. And I think that's such a wonderful area of brain injury. A lot of times as a provider, you're just telling them what's wrong. And as the eye doctor, because eyes can get better, you're like, well, this is wrong, but this is how we fix it. And so for me, that's what kind of got me down this path and has kind of led me to where I am today.
I guess let's start with optometrists. Are there many optometrists that focus on working with brain injured patients like yourself? And if not, why are there not more doing that type of work?
Yeah. So when I graduated, there was no sports vision or concussion residencies at all. I was the first one to develop a concussion clinic in an optometry school. So the reason that we just have a problem is we have lack of awareness and lack of training. So the first thing I would say is who does brain injury? And that to me is very important because every brain injury is different. So some clinicians aren't really trained in it. And they're like, yeah, I do brain injury. I went to a conference and I learned over the weekend, but they didn't do a residency. And so in optometry, a residency is a year-long program where you're studying with attendings above you, and it's regulated by the schools of optometry. And in the US, there's only 4 of these residencies for neurooptometry. So we're only pumping out 4 of me a year. And that's an issue. Now, I will say in the last 5 years, the VA system has increased it. So they now have 6 more residencies. So we now have 10 of us coming out a year. But the majority of those in the VA stay in the VA because there's so much brain injury in the military. And because of that, we just don't have enough of us. And it's actually one of the reasons I moved to Virginia. I was talking to Dr. Zazzler on the phone because I was just looking to leave California. I was tired of almost lighting on fire every year. And he essentially said, no one does what you do in this state that has that much training. And he was like, if you move here, you can start your own practice and practice how you want to practice, which is like a dream to a clinician. So that's kind of what brought me here.
So what is the difference between an ophthalmologist, an optometrist like yourself, and then an optician, finally?
Yeah, I think that's the most common question we get. So an ophthalmologist is either an osteopathic or medical doctor. So they went to med school for 4 years. And then they do after med school where they learn a little bit about everything. They specialize in ophthalmology, depending on what they do, 3 to 5 years. So some subspecialists would be like neuro-ophthalmology or cornea or things like that. So they have additional training in that. They are a surgeon. And so they're going to look at things from a medical perspective and a surgical perspective. Optometry, on the other hand, so an optometrist, we go to college, but then instead of 4 years of med school, we do 4 years of optometry school. So we have 4 years of learning about the eye. And then our residency programs are optional. So it's an extra 1 to 2 years of training on top of the 4 years that we already did. And as an optometrist, it's kind of the wild, wild west right now because we have this really big extreme of how much people want to practice and what scope they practice because every state is different. So in the state of Virginia, optometrists now can do laser procedures and things like that, which is, going to be different than other states. But some optometrists just do glasses and contacts. Some do eye health exams. Some do double vision and neurooptometry. So it's really hard, I think, for many people to find the right fit and provider, depending on what the complaint of your patient or your worker is going to be. And then the optician is somebody who sometimes went to school. Apparently in Virginia, you don't have to be specialized to be an optician. And they essentially are the people who dispense your glasses and contacts. So they're going to order them and fit them and make sure that the frame looks nice on you. But they are not a doctor by any means. They don't look at eye health. They don't do anything that's related to the eye in that sense.
Is one of them more suited than the other to evaluate and treat brain injury patients?
I think it depends on each brain injury. So for instance, there is a role in surgery. Someone who's had a severe traumatic brain injury that's had a cranial nerve palsy and one of the eyes is just pointed in the wrong direction, they're going to need surgical correction. Somebody who maybe has optic nerve head edema because they have increased intracranial pressure, they're going to need an ophthalmologist. But a lot of the other complaints that happen in brain injury are very subtle, how my eyes coordinate, how my eyes focus complaints. And those patients, in my opinion, they need to see an eye doctor to make sure there's not an eyeball problem. But oftentimes they need someone who's specialized in brain injury to understand what's causing their visual complaint. So I think a neurooptometrist for those patients is usually the ideal.
Now, a lot of the folks on the call are specialists in the workers' compensation industry, and brain injury becomes significant to us because we've seen an uptick in claims of brain injury, and particularly in Virginia, if a claimant is found to have brain injury so severe as to render them incapable of gainful employment, it could convert from a 500-week case to a permanent case. So I guess getting a little bit more the heart of the matter, in which I think is fascinating, that the area of study of the eye and how you can look at the study of the eye, correlate that to diagnose whether you have a brain injury or not. But can you explain the science of that correlation between concussion, brain injury, and eye movement?
Yeah. So every single lobe of the brain is involved in eye movements. And eye movements right now are the only objective biomarker for brain dysfunction. So I think that's one of the frustrating things for a lot of people on all aspects of brain injury care is that we can't really see it on most people. They walk into your office, they can walk, they can talk, especially patients with a mild traumatic brain injury or concussion. And so they look normal, but then they tell you this whole list of symptoms. And then the hard part is, do they have them? Do they not? And one of the things that I love about the eyes is people can tell me whatever they want to say about their symptoms, but their eye movements will tell me if they really have a brain injury or not. In the majority of them, there is a subset, maybe about 20% of people who are not going to have eye movement problems acutely. And so those ones, you're going to have to diagnose them a different way. But the majority of patients are going to have some type of eye movement abnormality.
Okay. And so just a reminder, folks, put your questions in the chat room and we'll address those when we get to the end of the presentation. Dr. Theis, perhaps now we can turn to the slides that you wanted to kind of talk a little bit about more of the medical side of the correlation.
Yeah. So let me make sure I have control here. Okay. There we go. So let's just start out a little bit. I wanted to give kind of an overview of traumatic brain injury as a whole. So epidemiologically, traumatic brain injury is really common. And we know that there's 64 to 74 million new cases of traumatic brain injury each year. And I know that you said that there's a huge uptick in workers' comp cases with brain injury, but in general, we're seeing an uptick in brain injury. And the question really is, are we getting more, or were we just not diagnosing them before? And I think that's what we're starting to see is, number one, our definition of what a traumatic brain injury is keeps changing. And so as that changes, now all of a sudden we're diagnosing it more often. Of the people who have a brain injury, the majority of them are mild. So up to 90% of them are mild, and we'll go into what that means. But we have to recognize that oftentimes, now that we're more aware of what a concussion is because of all the mass media campaigns, that people are going to be more aware of their symptoms. So we were really underdiagnosing brain injury before, and people were just suffering with symptoms, not knowing what they had. And the other problem I always say with brain injury is, if you have an injury to any other part of your body, let's say I broke my arm on the job, my brain is going to register that I broke my arm. But if you hurt your brain has to be the one to assess that you hurt your brain, but the brain is hurt. And so you can see there that there's going to be an issue with people being able to self-evaluate their symptoms with an organ that's damaged, that's in charge of that. As I mentioned before, about 80% of people are going to have visual complaints after they've had a traumatic brain injury. And sometimes it gets linked into vestibular as well. So the vestibular ocular motor component, we know that about 70 to 90% of both kids and adults are going to have acute concussion problems with vision, and about 24 up to 30% are going to have chronic problems with them. And so, as you all know, when I talk to other audiences, everyone always just thinks of concussion. They think about sports and military. And that's because that's where the majority of research is being done and the majority of media resources are being allocated. But in actuality, the majority of traumatic brain injury just comes from falling or things falling on your head, which probably resonates with a lot of you guys that are kind of working right now, as well as motor vehicle accidents. And so one of the things that we have to keep in mind is that we do have people that are high risk. And so we want to be careful of those people. So people who are elderly, people who have mobility problems. But we always say in brain injury, one of the complications of it is you bring into a brain injury what you have pre-existing. So we know that people who have vascular complications or autoimmune disease, they're going to heal slower. So a lot of these metrics that are pumped out there about brain injury that say things like you should be better in a week are based off of studies in like elite high school athletes who have no health complications at all, no life stressors. And so we can't apply a lot of the data right now that's done in those populations on maybe an average population work group. And the other thing that's a big issue in research right now because a lot of these studies are done in men. And we know that traumatic brain injury in women can behave differently. And there's just not a lot of studies in women. So that's something that needs to be changing so that we can understand why brain injury might impact a woman different than a man due to genetics and hormones and things like that. So what is a traumatic brain injury? So a traumatic brain injury, if we think about what happens to the brain, and I think this is where people can get confused. Traumatic brain injury, you can have a brain injury without a head injury. So you can actually get hit in the body and torso so hard that you get whiplash on the brain to give you a brain injury. Or you can have a head injury without a brain injury. So they're not synonymous. So it's important when people make diagnoses that they diagnose, is it a head injury or is it a brain injury or is it both? In a brain injury, what happens initially is you're going to have the primary trauma to the brain. So either through a whiplash injury or through direct trauma, something falling on the head or you hitting your head on something. And that force is going to cause tissue deformation at the moment of the injury. And that's going to damage blood vessels and axons and neurons. And that can happen either focally or that can happen diffusely. And you can have a mild amount of damage or you can have a lot of damage. But then what happens is it's not just that initial blow to the head. Over the next 72 hours, you can have a secondary traumatic brain injury due to the inflammatory response that happens to the first. So again, I love analogies. If you think about, let's say you bumped your arm on something and it really hurt, over the next few hours, it's going to get swollen. Maybe it'll get red. Maybe it'll get bruised. It doesn't happen instantly. It develops over time. But the beauty of your arm is that it's surrounded by skin, and skin is really elastic. So it has a place for that swelling to go. The brain, unfortunately, is protected by the skull. And so if there's a lot of inflammatory swelling or lack of oxygen or blood that accumulates in the skull, that is going to increase your intracranial pressure, and that swelling can cause damage as well. And then if there's a break in the skull or there's enough breaks in the blood vessels and things like that, you can also get an infection and complications. So it really depends on the range of traumatic brain injury for what happens. But it's also why, because I get this question a lot, when this person went to complain to their employer about their accident, they didn't complain about symptoms A, B, and C. And that's not uncommon in traumatic brain injury. When I used to work on the sidelines for football teams, one of the things that would happen is someone would get hit and they had all this adrenaline, and then you would do their concussion assessment and maybe they failed some stuff, but not everything. But oftentimes for the eyes, I would do the eye exam on the sideline and they looked fine. But then I would see them 24 hours later and they would come into my office with all these new findings. And so it's not uncommon that some of these things actually develop over 72 hours up to a week after that first injury in a concussion. And it can happen even longer in a moderate or severe TBI, especially if someone's in an ICU. The thing that makes traumatic brain injury really hard to diagnose is that it continuously changes its definition. And I think that makes it really hard for a clinician, because a patient can go to one clinician and be diagnosed with a brain injury and go to another clinician and not be diagnosed with a brain injury. And it's because they're using two different definitions. But there's no standardized one. There's one standardized in concussion and sport, and that's the only one that's standardized in the industry, which is frustrating. So for instance, the evolution was, it used to be thought to get a concussion, you had to lose consciousness. But in actuality, you only about 10% of concussions actually lose consciousness. 90% of them never lost consciousness to have a concussion. We used to think you had to have a direct blow to the head to get a concussion. And now we realize, nope, actually you can get a direct blow to another part of your body and get a concussion. So there's a lot that we're still learning about brain injury and concussion. One of the big things that I always look at, and I ask my patients, so is the GCS, which is the Glasgow Coma Scale that's here. This is often done in an ER or when they go to a clinic. And so this is how you differentiate mild versus moderate versus severe TBI, kind of the old school way, but it's pretty synonymous and people use this pretty commonly. But you have to keep in mind that this was developed to really differentiate people in coma and be able to figure out how to treat people who are in comas. It wasn't developed for mild TBI. And so when we say that, the majority of patients have a mild TBI, it doesn't mean that the experience is mild. It doesn't mean that their brain injury doesn't last very long. It just means that relative to people who got a brain injury and are in a coma, their injury was kind of mild. So for a mild TBI based on the GCS, they might have lost consciousness, but if they did lose consciousness, it was for less than 30 minutes. And by definition, they have normal neuroimaging. So they're not going to have a skull fracture or a huge hematoma in the brain. A moderate TBI means that they lost consciousness for greater than 30 minutes and less than 24 hours, and they may or may not have normal or abnormal neuroimaging. And then a severe TBI is someone who's in a coma, which means they've been loss of consciousness greater than 24 hours, and they may or may not have normal, abnormal neuroimaging. And then if their GCS, which again is based off of your motor, verbal, and eye-opening response, is less than 3, they're considered in a vegetative state. And if it's 0, then they're considered brain dead. So that's kind of what that GCS scale is. And again, like I said, there's a lot of other definitions and documents out there that add other things to the diagnosis. So for instance, how much post-traumatic amnesia do they have? Do they have retrograde amnesia? A lot of clinicians will bring that into their diagnosis of concussion. And I am an optometrist. And so I always, I don't diagnose concussion, and I say that all the time. I diagnose ocular motor dysfunction consistent with concussion or consistent with development. But for me, it's outside of my scope to be the person who diagnoses the concussion. In my experience, it needs to be someone who's seen a lot of brain injury and is well-versed in being able to understand you have a brain injury with a head injury, or you just have a head injury and maybe you have some neck pain. And I think that's where it's really important to work with someone who has a history of brain injury experience. Now, going back to vision, which is why I'm here, oftentimes when we think about vision symptoms and concussion, most people just think about the top 3. So we think about light sensitivity, blurry vision, and double vision. And those 3 hopefully usually get sent to an eye doctor. But in actuality, when we look at concussion, there's a lot of other visual complaints that patients can have that are going to be due to the visual system. And the problem is that these patients will complain of these, but they'll get sent somewhere else and they'll be getting treated by someone else. So for instance, if a patient's dizzy, that could be a vestibular problem. But if the dizziness is always triggered by a visual task, like when I'm scrolling on a phone or scrolling on a computer, that is going to be a visual problem, and headaches are common in concussion. But if the headache is every time I read or every time I do this visual task, I get a headache, it's a visual problem. So it's really important when we're looking at these patients with persistent symptoms in concussion that we look at what is triggering the symptom, because that's usually what's going to give you the underlying cause. And even nervousness and anxiety in visually crowded areas like grocery stores, that's a visual problem. And what's neat is if we can identify it and fix it, we can get it to go away. And I like that because while vision problems don't cause sadness or depression, I will tell you patients who have vision problems and they can't do the things they enjoy, particularly light sensitivity, right? If I can't tolerate fluorescent lights, I can't go out to eat. I can't go to the gym. I can't go to work. I can't leave my house because the sun is so bright. And if you're socially isolating without any ability to communicate to other people, you can over time really develop a lot of these psychological symptoms of sadness and depression, which complicates your recovery. We know that once patients kind of get to that cycle where they're just really emotionally depressed, they're much harder to rehab than if you get them before they hit that state. And I did mention here, I don't know if you noticed, I didn't say post-concussion syndrome. So there's a big debate right now in our industry of do we call it post-concussion syndrome? And a lot of us say, it's because everyone's different. Maybe instead we just call it persistent post-concussion symptoms. And so it's more persistent concussion symptoms than post-concussion syndrome. And I think that's because a lot of people can have a moderate TBI and have persistent symptoms. So it's just kind of a change in the nomenclature that might come around, although the ICD-10 code is still going to be post-concussion syndrome because ICD-10 codes are always delayed. So when we think vision, everyone always asks me, and they're always surprised, how is the visual system so commonly impacted in brain injury? And yet most of the time the eye exam is normal. And actually of people who have a concussion, 85% of them are going to have a totally normal 20/20 eye exam, which is super frustrating for patients because they have all these visual symptoms and then they go to the eye doctor and the eye doctor is like, well, your eyes look great. Maybe we change your glasses a little bit, maybe wear sunglasses. And that's kind of the best they get from someone who hasn't worked with a lot of brain injury patients. But the problems with visual symptoms in the brain is rarely an eyeball problem. It's usually the brain's ability to interpret the eyes or move the eyes problem. And so I love using this slide to give people an idea of just how complicated the visual system is. So I want you to imagine for a moment that there's a soccer ball that's in front of you, and it just moved from the left to the right. So the image of the soccer ball gets translated from the front part of the eye to the back of the eye, which is the retina. And then that image is going to go down the optic nerve to the optic chiasm. So when somebody's looking at the eyeball exam after a concussion or a brain injury, we want to make sure that all the structures in the eye are intact and they're taking the information in. I mean, you think about it, if you get hit in the head hard enough for the brain to get damaged, you can get eye damage, you can get retinal tears and things like that. Not commonly, but they can definitely occur. And so we do want to rule out that none of that has happened. Then once the visual information from the soccer ball gets to the optic nerve, because we have two optic nerves, they crisscross information at the optic chiasm and they go to the midbrain. Some of the visual information, about 10% of the visual information from this pathway, never makes it to the back of the brain. It goes in what we call non-image forming visual pathways. And the reason I bring these up here is because these are the ones that are actually really important in brain injury. So the light signals here will go to the hypothalamus, which is going to help with our circadian rhythm. So a lot of our patients have a lot of sleep problems. And one of the theories right now is that it's actually a light problem due to poor interpretation from the retina. We have circadian rhythm issues due to the hypothalamus. It also goes to the thalamus. So when patients have light sensitivity after brain injury, particularly in migraine and things like that, it's this visual pathway that's causing the light sensitivity for these patients. And it's a very specific wavelength that triggers it. So for these people, sometimes certain tinted lenses can really help them. And then the third place that this goes is the pupillary reflex. So that's as far as brain injury goes. When I'm looking at the afferent pathway, which is this blue one, I want to know, how are the pupils doing? How is their sleep and circadian rhythm? Because blue light can really impact that. And how is their light sensitivity? And then the visual information gets to the back of the brain. So normally when you send someone for an ophthalmological or optometric exam, they're going to get a dilated eye exam and they're just going to look at this blue pathway, which oftentimes is normal, right? And so the problem is that's not how people see. So the information about the soccer ball gets sorted by the occipital lobe, and the occipital lobe sends that information to the temporal lobe. And the temporal lobe is what we call our what pathway. So it's involved in object recognition. So essentially it talks to the hippocampus and it says, this black, white, round thing, we've seen this before. We call it a soccer ball. And then at the same time, the parietal lobe gets this information and it says, I don't know what this thing is because the parietal lobe doesn't do object recognition at all. But it says, I do know that it used to be located to my left and now it's to my right. So it gives you that spatial orientation concept. So when you hear people don't know spatial orientation, it means they don't really know where they are in space. And it's usually a parietal lobe problem. And then the frontal lobe gets all that information from the parietal and temporal lobes. And it essentially says, I want to make an eye movement to follow the soccer ball. So the frontal lobe is going to be what decides to move the eyes from the left to the right. And then, of course, if you move your eyes and you move your head, the vestibular system gets involved. And if you decide to kick the soccer ball, your cerebellum gets involved. So in something as simple as moving your eyes from the left to the right, you've just used every single lobe of your brain. And making an eye movement from the left to the right is different pathway in the brain than going right to the left, which is different than up and down. And so if you really do a comprehensive ocular motor exam, you can get a really good grasp of neurological function. So to go back to Scott's question earlier, how are the eyes and brain connected? Intricately. Over 70% of the brain circuitry is involved in how we see. And so that's why there's so many atypical visual complaints. So this is why sometimes people can be anxious or they can have trouble. I've had patients with visual problems where they develop a stutter and they can go to speech therapy all they want, but the problem is actually a visual problem. So once you fix the visual pathway, the speech will realign itself. So it's a really complicated but fascinating system. And so this is my big problem and why I like to get on the soapbox is we have a lot of post-concussive symptoms and signs. And currently the main ones that get sent to eye doctors are on the left-hand side. So double vision, blur, and light sensitivity. But in actuality, the ones that really are prohibiting people from going back to work or going back to their lives are the list on the right. And they're often just told it's going to get better and wait it out, or they're just told that they're faking. That happens a lot, unfortunately, for patients who are treated by people who have never had a brain injury themselves. And so it's really important that we just understand, hey, if this person's not getting better, we need to rule out that it's not an eye problem. So Slide delay. So there is something you guys might be seeing propping up, especially if you refer people to vestibular physical therapists, which are excellent. I love working with vestibular PT, and it's called the VOMS. And so there was a bunch of concussion doctors in Pittsburgh that found, hey, this is a really good screening assessment for brain injury. And so what they did is there's 5 different eye movements in the vestibular ocular motor screening assessment that can be done. And essentially you do the eye movement and then you ask the patient, are you dizzy, nauseous, headachy? And then you kind of calculate it. In general, we know that none of these eye movements should be giving you physical symptoms. You should not feel dizzy and nauseous when you move your eyes side to side. You shouldn't get a headache if you're moving your head side to side. And so what's cool about this screening test, anyone can do it. It doesn't have to be done by a specialist. And they found that this test was 90% accurate in identifying patients who've had a concussion and patients who don't have a concussion. So I love using the VOMS mentality of symptoms in addition to signs. So not only do you need to have abnormal eye movements, but you need to have symptom provocation with eye movement. And someone took the control back. John, if you can go next slide. Oh, give it back. Give me a second. There we go. Interestingly, we know that women will have higher VOMS scores than males, and that's not uncommon. Women tend to have more concussion symptoms than men. One of the theories is actually because, well, one is genetics. We know that genetically they're going to have different reactions and inflammatory responses, but the other is also the neck. So the neck is often an under-evaluated structure. If you get a head injury, you're going to get a neck injury because the neck is holding the head up. And so women in general don't have as strong of necks. And so they're more likely to have this torsional component when they get their head hit. And that can often stir up a lot more vestibular and ocular motor symptoms. Now we know, again, a lot of these studies are done in athletes and done in kids. So sometimes you have to take it with a grain of salt when you apply it to adult population. But in general, this test should never provoke symptoms in someone who is healthy unless they have a history of BPPV or some weird inner ear disorder. So it's a really good screener to be like, is this eye movement caused by the brain injury, or is this eye movement a problem that they had before the brain injury and now we're just finding it because we're looking for it? And that is one of the things that I work at a lot is, what is it, chicken or the egg? Did it come before they had the brain injury and now they're symptomatic for it? And that's important because when you're doing rehab, if someone has, a congenital problem with eye movements, you need to know where you're going with your rehab because that person may never be normal because they started out abnormal. But the big thing is they should be asymptomatic if they were asymptomatic before their injury. So as far as how many people have this kind of dizziness, nausea, headache, brain fog with eye motion and head motion, about 80% of people acutely, and this is important, 80% of those people will totally self-resolve in 3 to 4 weeks. So in my opinion, not every single person needs a neuro-optometrist. We know that it's going to go away. And I often tell people, because they get all worried that they need to come in right away, it should go away in about 3 to 4 weeks. We do know that about 20 to 30% of people don't get better in 3 to 4 weeks. And those people need to be referred for active rehab because we can actively get those symptoms better faster if we can intervene. But really acutely, you can just kind of let them wait it out a little bit if you want. And one of the reasons that I also like the eyes is because the eyes are being looked at as one of the best ways to determine when the concussion is actually resolved. So balance, for instance, is probably one of the best ways to detect a concussion because it's one of the first things that goes. But balance gets better really quickly. So it's not the best way to gauge when the concussion is over. Same with symptoms. Sometimes symptoms can improve but linger, and symptoms, as we all know, is dependent on the person. You have some people that are just tough as nails and don't complain about anything, even though they're hurting a ton. And then you have some people who are not the toughest and they complain about everything. And so symptom scores in general aren't the best way to tell if the concussion is better or not. We know that in general, cognitive recovery can take 1 to 3 weeks. But in a normal concussion, so that's what this study looked at. It looked at in a normal concussion in a student athlete. So again, young, healthy, pristine person with great health. it will take 3 to 4 weeks for their ocular motor symptoms to get better and recover. And that's important because if they have ocular motor problems at initial diagnosis, you know that concussion is going to last at least 3 to 4 weeks, probably, which I think is helpful to let people know. Because if you tell them your concussion is going to last for a week and it lasts for 4 weeks or longer, you get a lot of psychological overlay, just worried that something else is wrong or something was missed and things like that. So if you just give them kind of the, hey, your eyes are involved in your concussion is going to last a little longer. I find that it's just better patient management and they just don't get upset. Now, in this paper, they mentioned you need to be aware there's a lot of other things that can make a concussion last longer. So studies show that someone who's in litigation, their concussions tend to last longer. Workers' compensation claims tend to last longer. Individuals have motivation, right? So you have some people that really want to go back to work or really want to go back to play, or you have some people who really don't want to go back to work or don't want to go back to play. And so that can be a factor in concussion resolution. Age, we know that the older you are, the slower you recover. Gender, females take a little bit longer than males. If they've had concussions before, it can take longer to recover from a concussion. And then premorbid factors. So the big things for us is like, if you need to be able to sleep, you need to be able to eat. And so if someone in general is not a healthy person, they've never had great sleep habits, they don't eat regular meals, and they're not the healthiest individual, they're bringing that with them into the brain injury. It's going to make it a little bit harder for them to recover. And then, of course, injury severity, and then what type of treatment do they get, and how quickly is it intervened, and when do they get it? So that kind of concludes my slides.
That's all great information. Thank you for that, Dr. Theis. And I see the questions are coming in, so keep them coming in, and we'll get to those at the end of the presentation. One of the challenges we see in workers' compensation, particularly with the professionals that are on this call, is just whether or not the person really has a brain injury or not. Obviously, because we're dealing with workers' compensation patients, there's sometimes the motivation to exaggerate the symptoms at a minimum. Can you talk about some of the objective tests, the actual tests that you're doing when the patient comes into your office? What are those objective tests? What are the names of the tests, and exactly what are you doing? I think probably a lot of folks are familiar with things like the pupillary light reflex, where they put the light in your eye. But what tests are you doing? Which ones do you like, and how do they work?
Sure. So I think the big one that people know a lot about or hear a lot about is convergence problems. So convergence testing is really easy to do. And so all you do is you take a target. Now, target size matters. So this actually can get missed by a lot of clinicians. If someone just uses their finger and says, follow my finger and tell me when you see 2, and they go quickly and they use a big target, the patient who has slowed processing speed might not say it went double till here, but really they saw it double back here, but they're slow to say it. Or because it's moving so fast, they actually just don't appreciate the double. So the smaller the target you use, the more accurate, and you do need to go slower than I find most clinicians do in busy clinics. But essentially, when you bring a target towards you, so I usually tell people, if you have a pen, just use the small writing on a pen. And if they're looking at it and they say that it goes double way back here, we call that convergence insufficiency. So essentially the eyes are coming in, and then when the eyes can't converge anymore, one of them turns outwards. And so they see double. A normal person of any age should be able to get this pencil all the way to their nose. So that's an easy one. And it's objective because I can usually tell when the eye is starting to drift off. And it's one of the reasons that I like it the most. In brain injury, when you work with these patients, oftentimes when it drifts, they get a lot of symptoms. They don't feel good. They're a little dizzy. In patients who have this problem developmentally, because about 20% of people can have convergence problems just because they were never a great reader and no one identified it as a kid, they're not going to have the symptoms with it. So you'll do it and maybe the eye drifts, but the eyes turned out and they don't see double because their brain has adapted to it and just shuts that eye off when it drifts out. Or you do it and you're like, how do you feel? And they're like, yeah, it's fine. So that for me is where I was saying, when you pair the symptoms with the objective signs, that's when you can really tell if it's a brain injury or not. Some other tests that we use. So in my clinic, I use what's called the developmental eye movement test. Other people will use what's called the King-Devic. And so that's an eye tracking test. The difference between the DEM and the King-Devic is that the DEM doesn't require a baseline. And that's why I like using it in my clinic, because if I've never seen a patient before and I don't have a baseline test, I need a test that gives me information anyways. And so the developmental eye movement test has age norms. So I can at least compare to that if I've never seen the patient before. The King Divic is used a lot in athletics because it's fast. You can do it on the sideline. And essentially what it is they just read numbers out loud and you time them. And then if they get hit in the head again, you do the same test again. And if they get slower, they're more likely to have a brain injury. And studies have been used on that test time and time again and shown that it's a great sideline screener to pull people from play. But it's only really helpful as a sideline screener within like the first 72 hours. And so there is some caveats to that test in general. Another test that I like to use. So obviously we have 7 different eye movements. So I'm going to evaluate each one. There's a tool called the ocular motor assessment tool. And so what it allows me to do is count their eye movements over time and then time how long it takes at the same time for them to get symptoms. So we know someone should be able to make an eye movement for about a minute before they feel kind of gross. So if you're doing an eye movement test with them and they're slow and they can't finish the minute because they get a headache right away, that's usually a red flag that there's a concussion going on. And then I also like that a lot too, because as you're doing rehab with them, they still feel gross until they're better. And so I like having them come back in and rechecking them on this ocular motor assessment tool because they can see some progress. And it also tells me, because I do all my therapy, I have them do it at home. And so if they come in and their numbers aren't getting better, they're either not doing the exercise or they're not doing it correctly. And so it's a really nice objective way for me to see what their progress is. And I know what norms are, right? So if you started here and this is where we're going, I can say you're 30% better, 50% better, 70% better, which I think is super helpful. And then the last thing that I use in my office is an eye tracker. I really like using an eye tracker for a couple of reasons. One is to screen out people who are really good with functional overlay, right? They're really good at faking it. And they're, I will say rare. It is rare that you'll see them, but you'll see one occasionally. And what I love about the eye tracker is the eye tracker doesn't lie, right? And so what it does is it literally videotapes their eyes and it measures the movement. And if you do it enough, you can start to recognize patterns when people are trying to fake the eye tracker versus, oh, this is actually like a problem. And so sometimes I like to use that as an objective way to see, are the eyes really a problem, or are you just on purpose not participating in my exam? But like I said, more often than not, I find that the patient actually does have relative complaints. They're just, not being evaluated properly. But I would say occasionally you'll get someone who really is just trying to milk the system. So.
You mentioned the convergence. It seems like that's something perhaps a layperson could test for. Are there other tests that a layperson, somebody who's not a specialist like yourself, could test a person for brain injury?
So the VOMs, and so I mentioned it in my PowerPoint slide, but you can literally YouTube VOMs and see how it's done. But you just take, fingers and have them look side to side. You can do finger in and out. You can have them follow your finger side to side and up and down. And then the big hitter, I always say that because it's the most frequent one to give people symptoms, is you have them look at their finger and shake their head at the same time. And if someone's really symptomatic from a concussion, you're gonna see it on that one. Because they're gonna not be able to do it, and they're gonna not. I do that. That's the last thing I do in my exam because it just destroys people usually. So
I'll have the adjusters save that one. Maybe they could do the recorded statements by Zoom and pull that one out. That'll be the zinger at the end. But Dr. Theis, is there any current technology or software available or on the horizon to evaluate or diagnose brain injuries?
So right now, eye tracking, there's a lot in industry right now looking at eye tracking because it's objective, number one. And as we saw previously, it has a wide field of distribution where the eye movement pathway can go wrong. So where someone gets a brain injury is likely to flag with an eye movement problem if you do a good software battery. And then as you saw in the earlier slides, a mild traumatic brain injury by definition has normal neuroimaging. They have a normal MRI. They have a normal CT scan. And so it's really hard to track the brain injury if all those are by definition normal. So that's where eye movements have been coming in. And there's a really cool eye tracker that is being used in Pittsburgh right now. And it looks at what we call micro nystagmus or microfixational movement. So this is eye movement that even I can't see on my eye exam. And what they're finding is that of the patients who had an acute concussion, the ones that had micronystagmus eye movements, they actually were more likely to have a longer recovery in their concussion than those that didn't have it, which is huge. If you can start in the very beginning of someone's injury, be like, ooh, you're going to take a while to recover. I think that's so valuable. That's still being in research, though. It's not FDA approved, but that's on the horizon of kind of where people are going. And then, of course, there's blood markers and things like that, but blood draws are a little out of the optometry realm, so not something I'll talk about today.
You mentioned it was rare, but can a person indeed fake or feign eye movements during an exam to try to show a brain injury when it doesn't exist?
So that's what I like about the near point of convergence test is they can say they see double, but if you don't see that eye move away from the target, you can't fake it. Like you can't say that I see double back here, but both of my eyes are perfectly pointing towards the target. So convergence is a really great objective test that you can't fake. I think some of the saccade testing can be faked, and some of that's my big problem with VOMs is it's not objective, it's subjective. So you're really doing the eye movements and asking the person for their symptoms. So yes, if you have someone who is inflammatory about their symptoms, they can definitely kind of get the system that way. But that's where it's important to work with someone who is really well versed in vestibular or ocular motor assessment to be able to tease out the objective part of that test and say like, well, yeah, they're symptomatic for it, but objectively they're fine. And that's a good way to do it.
So you have a patient who has an actual brain injury. Does vision therapy or glasses or prisms actually improve the brain injury or the concussion?
Yeah, well, whether it improves the brain injury itself is hard to say, but I will say it will improve the visually driven symptoms. So I can't read for longer than 10 minutes. I'm light sensitive, things like that. We know that vision rehab not only improves those symptoms, it will get people better faster than just resting at home. And the sooner we can get people to feeling better and back to work, the better, really.
So you promote active eye therapy as opposed to simple rest?
I do. So studies have shown that rest is really critical in the acute period. So we want you to rest in the first 72 hours up to 1 week after the injury. But after that, active the studies are we call it the Goldilocks effect. If you rest too much, you don't get better. But if you don't rest enough, you don't get better. And there's this bell curve in between. And so oftentimes we find that it's figuring out what is that balance of I push my system, but not too much. And sometimes that takes a clinician to help them, especially with return to work, being able to guide them through like, oh, that's too much. Or if you do breaks this way, we can kind of guide you through that so that you can continue to recover.
And so one of the challenges for adjusters is if there's a brain injury and treatment is needed, what is the appropriate amount of treatment? What's your opinion as to the typical period of treatment required when you believe that somebody needs active eye therapy?
Yeah, I think this is the question every provider hates getting from adjusters and case managers of like, well, how long? Especially when you see them on the first visit. And you're like, well, how long is it going to take to get better? I will say candidly on the first visit, it's really hard for me to predict how fast someone's going to get better because I've had some people that come in as a train wreck and are better within 2 to 4 weeks. And I have some people who I'm like, it's not that bad. And then they just take longer. And so for me, I can usually predict it after the first 4 to 6 weeks of how fast they're getting better because I have those number metrics. So I can get a good steady stance on it. In general, if this is their first brain injury and they don't have what I call barriers to rehab. So barriers to rehab are like constant chronic headaches and migraines where they're just in so much pain, they can't do the rehab. And they're actually doing the rehab. If they usually will get better in some, like I said, 4 to 6 weeks, 3 to 6 months on average. And then there's some sticklers that'll be 6 up to 12 months. But my big thing is, because I don't know someone around here said like, once they're a year out from their brain injury, they're done healing. And that's absolutely not true. I get people who are 5 years out, come see me and we can get them better. But it's the time from when you started rehab, because sometimes I'll get a referral and they'll be 9 months out from their injury and I just start them in treatment. And then I'll get a note that's like, well, they're 10 months out from their injury, so they're probably not going to get better. I'm like, you've only given me a month. Like, you haven't given me any time to get them better. So for me, it's knowing, number one is the eyes have numbers and metrics, so we know if they plateau. But the sooner you can get someone into the appropriate rehab, the faster they're going to get better. So that's the other key to it too, is if it takes someone a year to come in to see me, it's going to take them longer to get better because they've usually developed a lot of really bad behaviors to avoid doing the things that I need them to do, particularly with light sensitivity. So with light sensitivity, if there's one thing I can tell everyone, wearing sunglasses indoors will make their light sensitivity worse for longer. And so these people who've been wearing sunglasses indoors and cocooning themselves for hours and days at a time, if they do that for a whole year and come see me, it's going to take forever to get their light sensitivity better because you have to light readapt them. You have to get them to start behaviorally wanting to go into light, and they've flared it up by avoiding it for so many months and years. So if we can avoid that, we can get people better a little faster.
So let's talk a little bit about return to work. So the employer has light duty work available. Are there modifications that you generally recommend to allow a brain injured person that has some visual disturbances that accompany it, get that person back to work quicker?
Yeah. So ocular motor system in general is a fatigable system, and it will usually provoke symptoms for people in about 15 to 20 minutes of computer work. So something as simple as, hey, every 15 to 20 minutes, take an eyeball break, which is just close the eyes for a minute or two, and then get back to work and doing it in little 15-minute chunks. They'll actually be able to do more work without as many symptoms by the end of the day if they break it up into little pieces. For me, the big thing with return to work that really impacts the eyes is computers, because, the brain wasn't really made to be on computers for 8 hours a day, but that's pretty much everyone's day to day now. So it's important that they get breaks. The other big thing for me is ergonomics. If there's one thing we can do for people who have computer problems is to make sure they have proper ergonomics. So if somebody's had a brain injury and they have headaches because of whiplash, if they have multiple screens and they're constantly going like this all day and they have a whiplash injury, they're going to have horrendous symptoms by the end of the day. So one of the things is a good ergonomics assessment. Maybe we actually put them on a smaller single screen so they're not messing with their neck all day, and making sure that we give them the tools to make them a little bit better. And I find oftentimes people do the opposite of what they should do, right? They're like, I'm going to get a bigger screen or 3 screens. And usually you actually want to do less screens, smaller font size. Make it so you make less eye movements, not more eye movements. But it's not intuitive, because when we think about how we help, some of our elderly people who maybe can't see, that's what we do for them. We make it bigger and we make it, larger. But for brain injury, you want to do the opposite.
Now, Dr. Theis, the insurance adjusters that are on the call, many of them take recorded statements, and during those recorded statements, ask a series of questions to determine, the scope of the injury. When dealing with a brain injury, some of the questions obviously are probably fairly obvious, like if you've had trauma to the head or loss of consciousness. But are there certain questions that you would recommend that they tease out during the recorded statement for subjective complaints that would assist a provider later in determining whether or not there is a legitimate brain injury or not?
So mechanism of injury is huge, I think, for one. Asking them, trying to assess if you think that they remember things correctly. So post-traumatic amnesia is huge. It's a good predictive factor for us on how bad the brain injury was, as well as dizziness. So we know people with dizziness acutely tend to do a little bit worse. So it's helpful for me to know when that dizziness kicked in. For me, light sensitivity. When the light sensitivity started, because the differential diagnosis for why they're light sensitive is pretty vast. And sometimes the light sensitivity is being caused because they got put on some migraine medication that causes light sensitivity. So if I don't know when it started, it's going to be harder for me to figure out what caused it. But I think also, when you take these intakes, like I said, recognizing that they might have symptoms develop over the next 3 to 7 days. So the symptoms, if you take that intake within an hour of that injury, their symptoms might not be the symptoms that they're going to have in the next 3 to 7 days if it's a brain injury.
Are there any questions that you would recommend they ask to maybe ascertain or tease out baseline, like education or learning disabilities or any diagnoses that may be important or not?
You know, I don't know if any of those are necessary. I think when we look at risk factors for why people don't get better, I think those come into play. But the big thing for me is, what symptoms did you have before? So for instance, migraines. There are a lot of people that have migraines. What was the frequency of your migraines before your head injury versus after? A history of migraine, usually migraines are going to flare up, and that's going to be a big barrier to getting better. It's really, I think, understanding what kind of things they were dealing with before the injury is important, but I think most clinicians, I would hope, are going to tease that out anyways.
Okay. Do all brain injured individuals need to be seen by an optometrist, ophthalmologist, or an optician?
I don't think so. And I'm sure I will anger all of my colleagues by saying that. I don't. I think that the majority of patients, like I said, 80% of them are going to get better in 3 to 4 weeks, and they definitely don't need a subspecialist to do the evaluation. I think we just need to make sure that we're screening for it better for the people who have persistent symptoms. So I think somebody who's got persistent symptoms that are just not getting better with other types of rehab, I think they need a referral. Now, big referrals for when should I send to ophthalmology or regular optometry? If they have eye pain, especially in one eye only, that can be because of a neck problem. More often than not, it's a neck problem, but you need to make sure that they don't have inflammation in the eye and things like that. So those need to see, just any primary eye care doctor is going to rule that out. If they have bright flashes of light or floaters in their vision right away, that's a sign of a retinal tear. Those patients need to see an ophthalmologist urgently for a dilated eye exam, because the retina is kind of like wallpaper. If you get a little tear and you don't treat it, it'll just rip off the whole sheet of the retina, and it'll detach. But if you can catch it when it's just a little tear, you can just kind of paste it back on, and then no harm, no foul for the patient. So for us, the big symptoms are going to be flashes of light, floaters, and vision loss. Those people all need to see. If someone says I'm missing a quarter of my vision or a piece of my vision, they need to see an eye doctor urgently.
So you have a legitimate brain injured employee, somebody that's been hurt at work. Who should be quarterbacking the care for that brain injured patient? Should there be multi-disciplines involved? Is there a particular specialist that you think is best to oversee the care for the patient?
Yeah. In my experience, and again, I'm biased because of where I work, but I think a physiatrist, a physical medicine and rehabilitation doctor, is usually the best point person for this, because they're trained in understanding what types of rehabs are out there. And rehab is so key to brain injury and getting them better faster. There's a lot of people who maybe aren't well-versed in rehabilitation, and they are really good at medication prescriptions, and that's great, but we need to make sure that all facets are being managed. I think it's key to have one person in charge. And I think sometimes the cases that get mismanaged is there's no one in charge. So you're asking a patient to manage themselves, and they've had a brain injury, so they can't even remember their own name, let alone what appointments they have scheduled or need to schedule. So I personally like a physiatrist. And the big thing for me is communication. I've loved working with case managers who will forward me other people's notes, especially if that provider maybe isn't the best communicator with me, because it helps me get the patient better and understand where the patient is. Now, some of my favorite providers that I work for, they will send me their notes and keep me in the loop of what they're doing, because what they're doing or what the physical therapist is doing might impact what I'm doing. So I think the teamwork is what gets people better the fastest.
Okay, and two more questions from me, Dr. Theis, and then I'm going to open it up for questions from folks that are on the call, and I'm going to let you drive those questions. But the first question is, you often hear folks say that we know very little still about the brain. Is that true? Do you agree with that statement? And how fast is the medical literature developing in the field of study and understanding of the brain?
We really have just barely tapped what we know about the brain. I think part of the problem has been we never had the technology to really understand it. And now we're finally getting technology to be able to see things that we were never able to see before. And so some of the things that we used to think, were true about brain injury a decade ago, now we're like, oh, nope, just kidding. This is totally different now that we have the technology to see it better. So I think it's changing rapidly. If you look at any literature search, it's just this exponential curve. If you looked at concussion and ocular motor diagnosis, maybe 10 years ago, there were 300 papers on it. And now there's a couple thousand. And the problem, it's a great thing, but it can be exhausting because the literature is pumped out every day, hundreds of thousands of paper on brain injury. And to be able to keep up with that can be exhausting. And so that can be frustrating, I think, for some patients, but providers as well.
And so many of the folks that are participating in the call today are nurses, and I know that you work with the nurses that come in with patients. Is there any practical advice that you would offer the nurses on how to more effectively work with a brain injured patient to improve the outcome of the patient?
Helping them get to their appointment. And it's, to give people I've had patients call our office and they'll say, hey, I got a reminder that I had an appointment with you last week. Did I come to that? Like the level of not remembering where they are, what they've done is drastic for people. So if they don't even remember that they did show up, can you really rely on them to remember that they have an appointment or they need to get there? And so I think our office works really hard to try and remind people this is your appointment and this is where it is. But if you can have another person really helping to remind them that it's there. And then for a lot of clinics, paperwork. If somebody has visual problems and brain injury, completing paperwork can be very difficult for them. And so oftentimes we will give it to them weeks in advance so they have time to have someone help them with it. But I think if you can help them with some of the paperwork, that can really help patient care as well.
Okay, great. And so we've reached the end. And so we've got some excellent questions, Dr. Theis, and I'm going to let you steer the questions. I know folks wanted to know how to find you, so I'll let you share your contact information. And I know they also asked about whether your slides would be available, and I'll let you address that as well.
Sure. So the first question we have is, can you provide more information about stuttering and TBI? So the only information I can provide is from a visual perspective because I'm an optometrist and not a speech and language pathologist. So we do know that it depends on the brain injury. Some people really will get speech deficits and cognitive and language deficits depending on where they got hurt in the brain. But some patients will actually start to stutter when they stimulate their visual symptoms. So for instance, they'll come into my office feeling fine, and then we do a couple of eye movement tests, and all of a sudden they can't get their words out at all. So that for me is kind of like a visually evoked system overwhelm. The way I describe it for my patients is, the brain, think of the brain like Internet Explorer, and it has a bunch of tabs open. So it'll have, I need my blood pressure to be good. I need my cerebral spinal fluid to be good. I probably need to be awake. So it always has those tabs open. And then you have a brain injury tab open that just sucks all the energy and the internet strength out of all the other tabs. And so when you start to stimulate the brain with a lot of visual or cognitive tasks, the brain kind of gets slow internet. And it's like, you know what I need to do? I need to get rid of some things. And so it starts to get rid of some of the things that are taking a lot of energy away, like speech. And speech is often the first one to go. When people get really overwhelmed or drained or just taxed in rehab, they're all of a sudden will start stuttering. And sometimes they go to speech and language therapy and it's, if it works, great. And sometimes, like I said, well, a lot of times it helps the patients. But if they're not getting better in speech therapy, it might be because the trigger for their stutter is not actually a pathological problem with speech. It might be that it's the brain's way of saying, hey, you're taxing this other system and that system can't handle it. So that's kind of where stuttering and vision comes together in TBI. The other question follow-up was, can I talk about vision therapy and how many sessions may be necessary? So this is a great question. I personally, and this is me on my soapbox, I hate how a lot of other practitioners do vision therapy in the brain injury population for a lot of reasons. So number one is they say a ridiculous number, in my opinion, of visits. They'll say, this patient needs 60 visits. And I'm like, I have never done 60 visits with a person in my life. What are you doing for 60 visits? And the other thing that I don't like about it is a lot of patients with ocular motor dysfunction are car sick. So if you put them in the car, they come to my office, my rehab is provoking. So everything that we're going to do in office is going to make them want to throw up. And then I put them back in the car. That's a horrendous experience. So oftentimes those in-office visits aren't very effective because when they go home, those patients are just lying in bed for days at a time because they feel so awful from the experience. So in my experience, I've found that home-based rehab for this group works awesome. And so I usually will give them a couple of exercises, make sure they know how to do it. And then I follow up with them every 1 to 3 weeks, depending on how quickly they get better. And the point of my follow-up is to make sure they're doing it correctly, make sure they're making progress. And then when they make progress, I need to change the exercises up to make them harder. and you kind of work them through it. So when I do that on average, I think I've had some people that get better in 2 to 3 follow-ups with me. I have some people that can take 10 to 20. But again, that just depends on how long they're taking to get better. It is an atypical way to do it, but I will say I lectured this year at the Neuro-Optometric Rehab Association, and I advocated that people start doing this for their patients, especially the ones that can't make it to their office. Because if it's just distance is the issue, like I can't make it to your office 2 times a week for the rest of my life, or however long they're being told that session is going to be, we need to make sure that we're flexible for our patients. And especially for those of you who maybe represent, I've had a lot of people who maybe were abused at work, right? So like a healthcare worker that was beat up by a patient. And so now you're also dealing with PTSD. And so when you're dealing with PTSD, getting a patient to leave their house and come to your office to do rehab can be hard. And that's the other reason I really like home-based rehab for them, because they can feel safe at their own home. And for me, when people feel safe and they have less stress and they're not anxious, they get better faster. So that's kind of, I can never quote how many rehab sessions I think they're going to take. Usually I can give a ballpark of 3 to 6 months for recovery. But again, every brain injury is different, and it depends on how many they've had before, how long it took to get it diagnosed, how bad the injury was. So it's really hard to predict. Unfortunately, which I know is not the answer you guys want when you ask me how long. And I'm like, I don't know, but I wish I had like a magic 8 ball and could just tell you all how long it would be. Okay. Next question. I haven't even talked about that. So this is a good question. So I am apparently describing an injured worker perfectly for this person, and she's seeing a concussion specialist, and they put her in special glasses, which she's having trouble adjusting to. She's 62 years old. They're about 1 year out. They've had several rounds of vestibular therapy. What is my experience on determining her long-term outcome? The first question I'd want to ask is why her glass is not working. So one of the things that happens in our older patient population is that they're wearing progressive lenses, so for reading problems. And patients with vestibular dysfunction can't tolerate progressive lenses. So one of the things that I do is I often take them out of the progressives, put them in a pair of single vision distance and single vision near glasses, get them to rehab the vestibular problem away, and then you can put them back in their progressives. But sometimes the problem with progressives, which is probably what this patient has, because the adjusting thing is usually what they're not adjusting to, they have these distortions on the sides, and the patient with brain injury can't ignore the distortion, and the distortion is what's making them dizzy and nauseous. So the second that you take them out of the progressives, all of a sudden their balance feels better and they don't feel as nauseous, which means they can now participate in therapy a little bit better because they're just not feeling so gross overall. My experience with a lot of patients. So one of the big things that I've found that people, because right now VOMS is like the hot topic in concussion PT, people are under evaluating the neck. The number of times I've had someone where they come to see me and they've been doing vestibular PT for eye movement problems, and they come to see me, I'm like, well, the problem is they have a neck problem. And to give people an idea of why that's important. So a couple of things. So if I'm moving my eyes rapidly left and right, sheer physics, if my eyes are moving this way really quickly, the only way my head doesn't move with my eyes is that my neck is actually bracing my head to not move. So when you engage your eyes without moving your head, your neck is turning on. So when people have trouble with saccades and they're not getting better in vestibular PT, it's probably because the neck is what's driving the symptoms, not the vestibular system at all. We also know that vestibular ocular reflex, so moving my head while I'm looking straight ahead and keeping my eyes open, it definitely involves the ears and the eyes, but it involves the neck. And so again, if we don't treat the neck, so you guys, for those that have seen me, you often see I refer to cervical PT all the time, and that's usually the missing link. And if we can get people's necks better, that usually drives a lot of symptoms. We know people with neck problems, their migraines are more frequent, their headaches get worse, their light sensitivity gets worse, and then all of a sudden you can miraculously kind of get them better. So my big thing is if they've done several rounds of a certain therapy and they're not making progress, it's not the right therapy for them. It can be an ocular motor problem, which ocular motor rehab is not the same as vestibular therapy. So vestibular physical therapists do eye exercises, but they're not trained in them. So they will hit a plateau at some point with certain patients because they don't have a wide breadth of other eye exercises to do. They just have a small niche window that they know works for the majority of people. So I'm a big fan of vestibular PT, but if the eyes aren't getting better with it, something else is going on. Okay. Next question is, If a patient has had prior concussions, what is the most beneficial information to have from their prior treatment to determine if they have returned to baseline? If I could get people to do better eye exams, that would be amazing. One of them for me is actually like pre-existing eye exams are helpful, especially some people have a lazy eye. Those are the harder cases. So someone who has a history of a lazy eye, I need to know what their pre-injury visual acuity was in that eye so I know where we're going. Because the vision can get worse. Maybe let's say their eye's normally 20/40, but then they come to see me, they're 20/80. I need to know that I'm rehabbing to 20/40. I'm not rehabbing to 20/20. So baseline eye exams are really helpful to know when they are at a baseline. A lot of the tests that I employ have age norms. So that's what I'll use for a baseline, because a lot of times the test that I'm doing, no one's ever done in an eye exam before for them. So they'll never have a baseline pre-injury unless they had a previous concussion. But even then, my exam is going to be different than other people's exams, which is what, again, like I said, we're wild, wild west in optometry. It makes it really frustrating because you can see one neuro-optometrist and get a totally different exam than another, depending on where we got our training from. Do I have any recommendations for neurologists that treat these types of injuries and also accept workers' comp? I don't know if you're asking for specific neurologists, which I'm candidly new to Virginia, so no. I don't have specific recommendations. I think neurologists are great. Some are going to be more open to rehab than others. I've had a lot of neurologists who don't believe in rehab at all, and I think that can be a barrier for some patients. I've had a lot of neurologists that are excellent and are like, oh, and they're really good at facilitating referrals. So I think for me, I just want to work with other providers who are a team player and open to referring to a different type of treatment, because every patient might need something a little bit different. And with concussion, we have trouble just doing research on diagnosing a concussion. The research on how to rehab a concussion is even worse because we don't even know how to diagnose it. So how we can research how we fix it if we can't diagnose it, it's just going to take forever to get good, solid research on the best way to treat these patients. To the person who was not able to get into the training until 2 p.m., we did record this session, so you can reach out to them afterwards. So they asked, one person asked, and I hope I already answered, what is my opinion on vestibular physical therapy? I think it's great. If you have a patient who can't tolerate it, I find that vision therapy first can be helpful. So I have a lot of patients that come to me. There's a lot of people, by the way, that go to vestibular PT and never see me because vestibular PT fixed it. So I'm a big fan of vestibular PT, but I have a lot of patients who failed vestibular PT because it was too intense. So essentially, the way that one of my physical therapists in our office described her education on vestibular was get the puke bucket ready because you're going to push them until they can't push anymore. That's not how we rehab the vision system. We're a lot more gentle. So if you have a patient that's tried vestibular PT and couldn't tolerate it, they often have a vision problem that we can remediate more gently. And then once the vision problem is gone, vestibular PT isn't as bad. So sometimes it's take a break from vestibular PT, do some vision therapy, and then go back to vestibular PT. Sometimes we do vision therapy and all of a sudden all their vestibular problems go away, especially if they've done vestibular PT before. And I think the reason for that is the ears, the eyes, and the neck all work together. So you need all three to work. And sometimes it's just that one little cog in the wheel that needs to be kind of tweaked. And then once it's tweaked, the patient kind of falls in alignment for rehab. I don't know how many visits, by the way. That was a great question. I have no idea. Ooh, great question. Whoever anonymous attendee is. So they asked, what about cell phone usage? We see folks that allege they can't be on a computer and can't watch TV, but can be seen in a waiting room using their cell phones for 20 to 30 minutes. Would folks
our private investigator on the line here, don't you think? Anonymous attendee, very.
Yeah, I know. And then would folks with the TBI have issues using cell phones? 100%. So I always in my office get my patients from the waiting room myself. For this reason, because if I walk in and I just kind of glance around our door and I see them in the waiting room and they're scrolling on a phone really quickly, that gives me a really quick idea of what they can handle. Now, that being said, some people are sitting in my room, they've got 3 pairs of sunglasses on and a hat and they're cradled like this. And, what does that mean? Who knows until we do the exam. But cell phones are usually going to be the reason that they're in my office. They can't even tolerate it. They have the brightness down. They can't look at it. They can't scroll on it. Now, some patients, if you really look at their phones, because I'll ask them to show me their phone. the brightness is on complete zero. Like I can barely see it. Their magnification is on 400%. And they're just trying to text a ride, and cognitively it takes them so long to do it that's why they've been on their phone for 20 minutes is it just takes them that long to get something done. So I wouldn't say I immediately judge a patient when they're on their phone, but a phone requires to be able to handle a smartphone, a couple of things. And this is the important thing for me, why cell phones drive symptoms in patients. So number one, reading requires all of your eye movements to be working perfectly. So if someone's reading for longer than 15 to 20 minutes without symptoms, the likelihood it's a purely ocular motor problem is low. It requires that they can tolerate blue light. And as I mentioned in my slide deck, blue light is often triggering of headaches and migraine and TBI. So if they can tolerate their device, and they'll say, oh, I have blue blockers. Over-the-counter blue blockers only block 30% of blue light. So those blue blockers are junk. They don't do anything. So I think cell phones are a great thing to look at. The other thing is head posture. So when we're on our phones, usually people are like this for long periods of time. And so usually cell phones are going to drive headaches for people because of the neck posture they're in when they're on the cell phone for a long period of time. So if they're able to tolerate that for long periods of time, I'm always suspicious. But to be candid with you, I think that's usually the rare part. Usually they're in complaining because they're like, I can't even look at my phone. And that's why they're in my office. But that was a good question. Is there a national registry for providers that we can use as a resource in other states? Yes. So one of the things with optometry is our licensure is a little different than other, than like MDs and other providers. And so our telehealth can also bridge other states. So do keep in mind that some providers can work in other states and some cannot. So there is that option for some people. And then the other thing is NORA, N-O-R-A. And when you put it into Google, you have to put in NORA optometry or you get like 5,000 other organizations first. So that is the Neuro-Optometric Rehabilitation Association. And they're the best way I can direct someone to find another neuro-optometrist. The big key, though, is when you click on their profile, I always read their profile. Did they do a residency, which means they did a year-long training in brain injury, or do they have what's called a fellowship in NORA or a fellowship in COVD, which you might see? And so COVD is the College of Vision and Development, which means that provider is really good at working with little kids with reading problems. In my experience, how you treat those kids and how you treat adults with brain injury is 100% different. And so sometimes my COVD providers, while well-intended, aren't doing the right rehab techniques for people sometimes, but they're better if you than nothing. And some of them are great. That's the hard part is it's hard sometimes to tell who's great and who's not for all of us on board. But I think we're getting better. So I would say that's the best way to start would be NORA. And then you can also look for under the profile of the doctor and see what their training is. Usually someone that did a residency, we put in the work and we got paid no money to do it. So we're going to put it on our profile for sure. Okay. Last question. What about latent complaints like dizziness, nystagmus, memory loss? Is this likely or not? So as I mentioned, dizziness can be a vestibular complaint. It can be a neck complaint or it can be an eye complaint. So sometimes dizziness is tricky because we have to figure out which one is the problem. Oh, and I forgot to do this, but this is a fun, like how the eyes and the neck are connected because this is a good one. If you were to put your hands on the back of your head and then just look as far over to the side as you can feel your neck flex. So sometimes with patients, what I'll do is I'll have them put their hands on their neck and then look all the way to the side. And if while they look, they get dizzy, possibly a vision problem. But if they close their eyes and look while their eyes are closed and they're still dizzy, the neck's the problem. So that's an easy like, oh, they've got a neck problem because my eyes were closed when I did it. So that's a good one for dizziness. And then vestibular obviously can cause dizziness all the time. Vestibular is usually the most likely cause of dizziness, but for those persistent ones not getting better, it's usually the neck or the eyes, as well as anxiety. Anxiety can cause dizziness too, and POTS, which I didn't get time to talk about. Nystagmus. So nystagmus is interesting because I found that physical therapists, they write anytime the eye jiggles funny as nystagmus. And in eye care, nystagmus has to be a constant rhythmic motion of the eye that doesn't go away. So we define it differently. I don't find nystagmus commonly in brain injury, particularly concussion, maybe in severe. They have to have pretty good brainstem damage for them to have a constant nystagmus or an inner ear problem. So sometimes with nystagmus, I think you have to make sure they actually have it versus a non-eye care provider diagnosed a funny looking movement. Memory loss can have, I think the question from this person might be, I'm hoping that, is it memory loss? Can you get memory loss from vision? You can have visual memory loss for sure. So people have trouble with visual memory. It's a visual processing problem. Memory in general, I think, can have a lot to do with cognitive resources. How much energy does that brain have? How much sleep? I mean, the big thing with everything that we deal with is how much sleep is that person getting? If they're in so much pain, they're not sleeping, their memory is going to be shot. And so I think it's looking at the patient from a whole perspective to figure out why they're having memory complaints. And sometimes it is cognitive. And those patients, the memory patients, do really well in cognitive rehab with like a speech and language or behavioral therapist. That's usually patients with persistent memory complaints. Usually we end up sending them for neuropsych testing and then behavioral rehab if they need it. If a patient has a history of anxiety and sleep problems, is there any objective way to determine if these issues are concussion related? This is why I'm glad I do eyeballs. I don't know, to be candid with you. I think that's where working with a physiatrist who's really well-versed in brain injury is going to be the best person to assess it, because sleep can be an objective and subjective problem, and anxiety is complicated. Everyone's anxious. I mean, if you live in the US, you're anxious. But the question is it situational anxiety? Is it neurological anxiety, psychological anxiety, visual anxiety? So I think some of it is you just ask the patient, were you an anxious person before? And I'll ask that to people. Were you anxious before the injury? And you'll have people like, yeah, I've been anxious my whole life. And you're like, okay. And then you have other people who are like, no, I was never an anxious person. I never worried about any of these things. And so you can just ask them. I think people are pretty good from that standpoint usually, or honestly, their spouse. Their spouse is going to be the most honest representation of their cognitive state, oftentimes, of what they used to be like and what they're like now. And how do you determine a patient is at baseline if they have a history of prior concussions with pre-existing symptoms? Well, for those cases, from which concussion am I rehabbing, I can't, right? So if someone comes in and they had a concussion maybe a year ago, they were still symptomatic for, and then they get another concussion, let's say at work, and you're trying to ask me, can I rehab just the work concussion and not the one before? Probably not, because I go based off of symptoms. Now, baseline is when they don't have symptoms anymore. And I will be able, in majority of cases, to rehab all of that. So, but if they've had multiple in a row and they're symptomatic from all of them, it is sometimes hard to tease out, which one, when can I get them to just the work-related injury? That I think is sometimes impossible. All right.
And I think that's the last question, and great questions from the audience. Thank you so much. And most importantly, Dr. Theis, thank you. I think it's obvious why you are asked to speak so much nationally and internationally. You obviously know this area very well, and this has been fun. This is a new format for us, and I appreciate your time today, and not only your time, but sharing your expertise. I do know that someone asked how to find you. So can you just briefly tell us, give us your contact information for folks that are on the conference that may want to reach out?
Yeah. So my practice is called Virginia Neuro Optometry. Pretty simple. And website is virginianeurooptometry.com. You can also just Google Jacqueline Theis and I'll pop up. So my name usually pops up before my practice.
And if you want to reach us, you can certainly Google us as well, Ford Richardson, and I'm here in Richmond, and we've got offices in Virginia Beach, Fairfax, and Roanoke as well. As Dr. Theis noted, we have recorded this for some of the folks that joined later. If you want to share it with your colleagues, feel free to do that. You can reach out to John Pettis, who's been on this call here at the firm, J. Pettis, Pettis at FordRichardsonLaw.com. So we'll sign out. But again, Dr. Theis, thank you so much. Thank you, everybody, for joining us today. Have a great afternoon.
Thanks. Bye.